Every resident fellow now, the number one thing they want is work-life balance. I don't know what work-life balance means. But it has nothing to do with the hours of the day. It has more to do building your world, which I've done. 99% of the patients come back. They're unbelievably happy and grateful. They're crying. And I really enjoy spending time with them. I love what I do.
Today we're sitting down with Dr. Richard Berger, the pioneer of outpatient joint replacement, world-renowned hip and knee surgeon, and the man who challenged decades of medical convention. In this episode, he shares what it really takes to build a legacy people travel across the country for. Entrepreneurship and bucking the status quo and being a disruptor. Are you passionate about doing that?
If you want to get me to do something, tell me you can't.
That's fair.
Part of the things is you have to be a little bit disagreeable to get things done. You have to go against the status quo and be comfortable with the fact that you're going to piss some people off by trying to make some changes.
Was there a moment that flipped and you realized I could do this?
The light switch moment for me was my daughter's first birthday. I missed my daughter's first birthday cake. I decided at that point I was going to drop out of Medicare.
That was the moment?
That was the moment. 41% of my cases were Medicare, but about 15% of my income was Medicare. And fortunately, I'm lucky enough that my numbers never went down, but my revenue went up.
Welcome to the Unhinged Podcast with Dr. Michael Meneghini, and I am thrilled, absolutely thrilled, to have an amazing guest with us today, the world-famous Dr. Richard Berger, who's a friend and mentor, and he's been kind enough to host us in his beautiful home in Chicago. So, Rich, welcome to the Unhinged Podcast.
Thank you. Thanks for having me, Mike. It's really a pleasure. Pleasure to be one of your first guests, and I'm excited.
Absolutely. Thank you so much. And I tell you, we've got a lot to talk about. The first thing I want to let the audience know, but most are already going to know this, is you have been an incredible pioneer and innovator in hip and knee replacement, and we're going to get to that in a little bit. But first, we start every podcast, we have a tradition of drinking some nice Italian red wine, and this wine has a unique story to it. This is an Amarone Valpolicella from Zenato, and the reason I selected this wine is because you are gracious enough to invite me to a meeting that you host every year in Vail. You have a particular restaurant, and a particular person who runs that restaurant who knows you and your wife, Marianne. This happens to be one of Marianne's favorite glasses. So cheers to a Valpolicella from Veneto, which is the area my family is from. So cheers. So let's get right into it. Rich, I think what we want to do with this podcast and conversation is give people, the audience, a glimpse into not only what you've accomplished, and we'll get into that, but what started the journey to create a world-famous hip and knee surgeon. Probably, I would argue, the most famous hip and knee surgeon in the world. And I don't say that lightly. I mean that. And we're going to get into that part of it. But talk to us about your childhood. I recall you grew up in New York, if that's correct. Tell us about your parents.
Yeah. I grew up in New York City. My mom was a bookkeeper. My dad had two jobs. He was a police officer in New York City, which is unusual for a Jewish guy in New York. But he also had a business where he built all of the animations for Macy's. Remember, for a long time ago, they had these huge display windows around Christmas time.
I did not realize that.
He did. In his basement, he and his partner, and it was all done in our basement. So as a little kid, I would go down, and it was Christmas starting January 1st through the entire year until right around Thanksgiving when they put up those displays.
So you're talking about those store displays in Macy's?
Those displays of the animations that go like that. You have to remember, this was 60 years ago, so there weren't electronics. These were stepper motors and gears and everything, and my dad would build these things down in the basement. We had a huge shop down there, and he would build these things, and we would watch him. We'd help him a little bit, and I got really interested in human motion, trying to mimic human motion with gears and stepper motors. Again, this was 60 years ago, and that got me really interested in biomechanics, and biomechanics led me to MIT. I was going to be a PhD in biomechanics and do biomechanical research, and I started working at Mass General Hospital with Andy Hodge and with Bill Harris, and I'm doing some research with them, and I helped set up their gait lab. I worked with a guy by the name of Bob Booth at MIT, who was famous for biomechanics and human motion. And I helped set up the gait lab that they were putting in at MGH, and I got to know Bill Harris pretty well. And again, I'm a college student, and I was doing research. And
so this is when you were at MIT?
This was at MIT. I was a college student. I started my biomechanical research in joint replacement when I was 19 years old.
You and I are very similar.
Anyway,
that's hilarious.
Anyway, so I went into, he called me into his office and we're talking about research and stuff, great. And then he puts everything down and says, "So Rich, what are you going to do?" And I explained my plan of getting a PhD in biomechanics and everything. He looks at me, puts down, and looks over his glasses and says, "That's really stupid."
Wait, wasting all that time?
Yeah. And I said, "Okay, what else?" And he explained, well, it takes the same amount of time to go to medical school and become an orthopedic surgeon. You should be an orthopedic surgeon, and then you can still do biomechanical research, but it gives you so much more opportunities and everything. I said, "Okay, great." And I took, again, this was 60 years ago, I took one class in chemistry, one class in biology, and applied to medical school with my mechanical engineering degree, and got into medical school. And the only reason I got into medical school was to do, my medical school application was why I wanted to do hip and knee replacement.
So you know how similar, this is crazy, and I'll share with you the same thing. I walked into med school the first day, and everybody's going around, I'm thinking surgery, pediatrics, whatever. And they're like, "What do you want to do?" I want to be a hip and knee surgeon. Everybody's like, "What in the hell is wrong with you?" So you and I have and both we're engineers. It was such similar background. Tell me about you're so successful. What did your parents instill in you that allowed you to become this? Do you think your parents had any, what did you learn from them? A New York City cop and a bookkeeper, that's an interesting.
My mom worked really hard, and my dad worked crazy hard. He worked 16-hour days, double shifts, 6, sometimes 7 days a week.
Holy cow!
So
did this in the basement.
Right, exactly. And I rarely saw him, to be honest. He was working 6 days a week, all crazy hours. You go on the shift rotation, so you're working 4 to 12, 12 to 8, 8 to 4. So God only knows when he's up. God only knows where he is, and he usually is trying to work double shifts to make overtime.
Well, because he's a New York City cop.
Exactly. So I got my work ethic from him.
It makes sense.
And I hope to instill that in my kids too, but that's where I got my
It's a little bit harder passing it on down to the next generation, isn't it?
So
I struggle.
hard to
I know.
do that.
I know. That's the.
You can't teach hungry.
That's a great phrase.
You can't teach hungry. You can explain what it's like to be hungry. You can explain what it's like to have nothing. But until you're hungry and have nothing, you don't know what that's like.
No, I think you're exactly right. And I think that's one of the challenges being a parent. I know, I'm sure you and Marianne, like Sarah and I talk about it. It's hard to create that in your children. You want them to be, but then you also don't want to have them go through the same thing. It's a conundrum as a parent.
It's so hard. I wish. And one of the things I talk about with everyone I go out to dinner with or meet with, have kids, is how to do that, is how to raise kids in, a relatively well-off lifestyle, how to raise kids.
How do you do that? How do you and Marianne do that with your kids?
I don't know. I'm going to ask you.
I was already having the rest.
Ask you.
If I had the recipe, I was going to take it home. Sarah, I found out what to do.
No, we talk about money with the kids.
Yeah.
We talk about how much things cost and everything. But again, I don't know about you. We had nothing. And when I went to college, it was the end of the month. For 3 or 4 days, I wasn't eating because I ran out of money. And that was with working part-time and doing everything else. Yep. So until you just don't get what that is.
Yeah, no, I remember my older brother and sister are younger, my younger brother and sister are a fair amount younger than me, but I remember telling them, when I got shoes, it was the Kmart Blue Light Special, and everyone was like, "What's the Kmart Blue Light Special?" My kids have no concept what the Kmart Blue Light Special is. I also where shoes came from because my mom was at the time a single working mother with 3 jobs, and that's what we had to do. So it's fascinating. But you're right. I don't know how we instill that in our children. That's a challenge.
My youngest daughter, probably about 7 or 8 years old, we're trying to teach her about money, and we put away a little bit of money for you. We started talking about that. We put a little bit of money for you, and it's not really for you, but it's to help you in a crisis, or really put it for your kids and you're to grow that nest egg by working. She understands. The next day she goes to Marianne, Mom, I'd like to get my nails done. And Marianne's like, well, we got our nails done, last month, and we don't do it all the time. So maybe next month. She turns and says, just going to be for my kids anyway.
That's so good. That's so good. Smart. It's very smart. Yeah. All right. So let's get back to the going into med school. You knew what you wanted to do. Tell us about the next step of residency. Tell us Tell the audience, where did you go to residency? Talk through residency, fellowship, and that journey, the mentors you may have had, and that path that led you. We'll get to Rush and some of your modern mentors.
Sure. So I stayed in Boston for medical school because I wanted to continue to research at Mass General Hospital, which I did for 4 years, which was a great opportunity. Got lots of papers, got lots of research. It was great. Discovered lots of cool things. Did my residency at the University of Pittsburgh because that was one of the few places that allowed you to do a year of research. But mostly, I wanted to go there to do a year of research, which I did, and met my beautiful wife there. And
is that where you met?
That's where we met. She was in hospital sales for a drug company, and I met her. And then I did research there. I spent a lot of time with Harry Rubash, who was really one of my first mentors, who was fantastic.
Yeah, great guy.
Did a ton of research with him in my year of research. Also got to meet and talk to Freddie Fu and did some research with him as well. I got a couple of shoulder biomechanics papers with him, believe it or not. But it was really Harry who was my first real mentor, who really taught me a lot and helped me along.
Didn't you and Harry publish the paper on femoral component rotation?
We did, actually.
Yep, I remember that. That was been quoted that's like the
forever.
paper. Yeah, that's great. So that was during your time when you were there?
That was my time doing research. CT scanners just came out.
Yeah.
They just you got to remember this is a long time ago. So CT scanners just came out. So we started looking at that, and we determined epicondylar axis and rotation and all that stuff, and wrote a bunch of papers. And anyway, and from there, I got to meet George Galante when he was a visiting professor, and we spent a long time together. And he was my greatest mentor. But I applied to a couple of different fellowships, and I applied to Harris's fellowship, was mostly hips. I applied to ISK, which was mostly knees. Yeah. And Rush was both hips and knees, which I really wanted to do. So again, this was before the match. So I scheduled all 3 interviews back to back to back because they would call you and give you 24 hours.
Oh, yeah.
So so I met with Dr. Harris, I met with Charlie Yang, I met with the ISK people, and they all told me, okay, you got like 24 hours to decide.
So you only interviewed 3 places, right? Or 4?
4. That was it.
Right?
You got to remember, this is a long time ago. A long time ago. And so George was the final one, and it was a great story because at the time there was 2 fellows, and they already had selected 1. So I get there in the morning at Rush, and there's 10 fellow applicants there, and I'm the first one in. And I talked to George, and we're getting along great. We're talking about research and all the things. It was great. And at the end of the interview, George says, "If I offer you this fellowship, will you take it right now?" And I said, "Yes, I will." He stuck out his hand. I shook his hand. He said, "One thing though, please don't tell the other 9 people that there's no spots left."
Interviewing behind you. That's spectacular.
Yeah. And that's how I got to Rush.
That is awesome. And then George has been one of your, if not your biggest mentor, right? He was a mentor to so many people.
George was fantastic. Not only was he a fabulous researcher, best surgeon I've ever seen operate, but he had such a big heart, just helped everyone, such a great person. He really helped me more than anyone, including my parents.
Professionally? And personally?
In any way.
Yeah.
He just gave me so much. He was great. And so I was going to go down to Texas to join Emerson and Head as my job. I needed something to do for 2 years before I went to MGH and ran the MGH program, because that's what Harry's plan was. And I needed something to do for 2 years. This was time there was no academic positions anywhere in the country. So I was going to go to Emerson Head for 2 years and then go to Boston, and literally 2 days before the end of the fellowship, literally a day before the moving van is going to come to take me down to Texas, George calls me into his office and says, "Look, we don't have any money, we don't have a position, but we really like you. Would you like to stay?" And I said,
well, that sounds like a great offer. We don't have any money.
And I said, "Sure."
Well, this is your
Marianne, my wife, was making a lot of money at the time, so I talked to her, and she said no problem. So I was making $30,000 as a fellow, and my first year in practice, they offered me $35,000.
Oh, jeez.
My second year, I got a raise to $60,000. But I figured it was a good place to start out, and it was, and they were fabulous. And then when the offer came along to go to MGH, I turned it down to stay here at Rush, and that's how I stayed here.
That's that work ethic, right? I don't see a lot of young. I see some, but not a lot of young people now, if I'm being honest, are going to take a first job for that and bet on themselves to make their way, right? I just don't see that as much. It's no disrespect, but it's just a different time and just different generation.
It's completely different generation. Our generation was, we will work as hard as we can to make a goal. We may make it, we may not, but we're going to work as hard as we can.
Right.
This generation is more like, look, I'm going to give you this. What can I get for it?
Yeah. Yeah, that's exactly right. Yeah. So you literally took a $5,000 raise, bet on yourself. You're like, this is the place I want to be. Cancel the moving van.
Right.
Now, I want to segue into something here. We'll get right back to that. You said something about George. He was a mentor, and he's best and researcher and best surgeon you've ever seen. This is going to piss some people off when I say this. You're the best surgeon I've ever seen, and I tell that to people. I tell that to people all the time. Now that I've said it publicly on camera, now I'm probably going to piss a lot of people off, but it is what it is. I'm at a point in I'm 53. I don't really care what most people think right now, so it doesn't matter. Except my wife and kids. Those are the ones and my close friends. That's what I care. But so it's interesting, our parallel paths. I think it's pretty cool and awesome. But George was a figure to a lot of people. I'll never forget one of my favorite stories when I visited Rush as a medical student, slept on. In fact, I saw this person at a funeral literally 2 months ago, and he goes, "You remember?" I didn't recognize the guy. "You remember you slept out in Lombard?" He goes, "Remember you slept on my mattress in my living room for a month rotating at Rush?" I did. I had no money either. I came up here and slept on a mattress, came in, did my visiting rotation at Rush, and I remember being in the room when everybody did the joint conference that George, at that time, was still very active. And I remember someone we know, I won't say his name out loud. He was a very young person at the time. That was when I was a fellow, I think. When I was a resident. This person got up there and said, it was in his first year of practice. In my practice, and I don't know if you were in the room or not. Like in my practice, this is when he was in his first year of practice. And George, I remember thinking this is going to get ugly. And George said, "You said what in your practice?" And I was like, "Oh God, this is going to be right." I don't know if you remember that moment, but that was it.
I remember that well.
Very good. Yes. Yeah, that was a great moment. So but George was the classy. Just a gentleman and a great person. So it's great to spend some time talking about him. Let's then talk about, you're in your first couple years of practice. And when did you start? What year was that?
So I started my practice in 96. Okay, Fellowship was 95 to 96, and my practice I started in 96.
So I arrive in 99. So you're in the middle of 99 as an intern. You are then a couple years in. Talk about the beginning years of the practice, because one of the things I really want to get into are the two things that you have been probably the pioneer in the world on two things: minimally invasive surgery, and the first one in the world to do outpatient same-day surgery. We're going to get into that a little bit. Tell us about those first few years of practice, how you were approaching hip and knee replacement at Rush at that time.
Sure. The first few years of practice, I was doing what a junior practor does, which is say yes to everything, right?
All the garbage is coming in, you're taking it.
You are the pus guy, you're the periprosthetic fracture guy, you're that no one else wants the crazy patients. And I was happy to do it, delighted to do it. I just wanted to be busy, work ethic, work as hard as I can. For the first couple of years, actually, Marianne was working in a different city. So we would only see each other on the weekends.
I vaguely remember
So for the first couple of years, during the week, I don't care. I'll be there till midnight. What do I care? I got nothing to do anyway. So I'll do any case, anytime. I took all the call. I did tons of cases. And I was making big incisions for hips, big incisions for knees, and doing a ton of revisions. I was doing a lot of research. And
by the way, one of your best videos, it's one of my favorite videos, is you doing a figure of 7. We don't do that anymore, but a figure of 7 allograft on the acetabulum.
Yeah.
Masterful. I remember it. I still can see it right now. That's back when you were doing big, crazy revisions, right?
Revisions.
It was awesome.
I would do. You got to remember, this was when there was a ton of cemented hips, both cups and stems.
Yeah.
And they got terrible osteolysis. They got I would do 4 or 5 hip revisions a week, every single week. Don't
you think that work prepares you to be a better primary surgeon?
Oh, absolutely. Absolutely. If you could take this crazy revision where there's no bone and make it work, suddenly, I don't care how hard the primary is, it's nothing, right?
Right. That's exactly right.
There's nothing you can get into with a primary that's not 100 times easier than a revision.
And it probably, correct me if I'm wrong, also allows you to be a better teacher, because then you know you can get out of almost anything. Because that's for me, I find teaching, I find more comfort in research. Teaching is the hardest thing I think I do, because me taking my hands off is, and I just fully admit that, it's hard for me. I'm a compulsive control. So for me, taking my hands off and watching someone else is very hard. But you,
it's very hard. It's very hard. In fact, I do it a lot less than you do. I mean, to be honest with you, the fellowship that I do, I'll take them through cases, but I'm not letting them do anything by themselves. I'm standing there. I got a new fellow who just started with me. She's great, but it started with how to hold the scalpel right, how to hold the bovie right. And she's looking at me, and she's looking at me like, I already know how to do this. I'm like, no, you don't. You really don't.
Right.
You really don't. And then 4 or 5 cases in, she's like, oh yeah, this is a lot better. I'm like, yeah. You mean you got to practice your craft?
I could not.
You got to be
more,
good
Rich.
at every single little step. We are terrible at training in orthopedics.
I agree.
Carpenters' apprentices are great. You watch for a long time. They teach you how to use every single tool. Then they say, let's build a cabinet. You can build a cabinet. We do the opposite. On the first day, we're like, you know how to use a saw? Yeah, you know how to drill. They don't know how to use a saw or drill. And we never really teach them the fundamentals. On my service, I spend the first couple of weeks teaching the fellows how to hold a saw right, how to hold a drill, how to use it, how to do these things. Because if you want to be really good, you need great fundamentals, or you're never getting really good.
I could not agree more. And I know I'm going to sound like an old curmudgeon here a little bit, but the robots are taking that away. We're seeing fellows come in. I mean, I'm trying to watch them cut through even a captured guide. And when when I did my fellowship at the Mayo Clinic, they were like, uncaptured guides. You need to learn how to cut through that. And they were focused on, if you're, let alone a captured guide, the saw's binding. You're like, oh my God, like it's like and they need to learn that psychomotor skill pattern to do that. And it's repetitive, I think. I agree with you completely.
You can walk down the hallway and listen to the saw in each room and know who's a good surgeon.
That's fair.
From outside. And as I tell all the fellows, the capture guides are like guardrails on a highway. You're not supposed to run into them.
That's fair. If your car's bumping around, it's probably not a good idea, right? That's a good point. All right, so let's talk about, then you do all these revisions. Tell me, because I think minimally invasive technique preceded the outpatient by just a little bit. Is that right?
Yeah.
So tell me, when did the light bulb go off? What made it go off? Why did you all of a sudden say, I'm going to head down this path?
Yeah. That's a great question. So you got to remember, this was, late 90s. And talking to George said at the time that if he was residency, he would not go into arthroplasty. There was nothing left to discover. Nothing left to do. He would do spine because there was a lot to do in there, but there was nothing left in our arthroplasty. So I was trying to prove him wrong. So I looked around. We did so much work in prosthetic design, materials, all of these things. No one had touched, or really thought much about touching, how the surgery was actually done. So I thought, at the time, like most people did, that the soft tissue that we buggered up, maybe was 10, 20% of the pain they had, but the majority was from the cutting the bone, putting the implant in. And everyone told me this was a fool's errand. It's only 10 or 20%, but I'm like, look, 10 or 20% is better than nothing. Why don't I head down this path and see what happened? So I spent 2 years doing cadaver work and developing implants. Zimmer was nice enough to help me. Yep. And this was way before anything happened with the FDA, but I would sketch out little things, fax it to them because there wasn't internet, right? Fax it to them, and I would have a piece of metal in my hand the next day.
That was when you
next day.
You could innovate so fast.
So I could play with things in the cadaver lab, take it to the OR, find it, and develop this minimally invasive surgery technique. And started with hips. And the first case, took me 4 hours to do because I wasn't really know what I was doing. I did it with an IRB, so everything was studied. Patients knew. The first patient
was this the 2 incision that we
started?
This was the 2
incision, yeah.
Because you've heard this. I was your assistant on 12 of the first 20.
I know.
I remember. I don't know which one it was where you went with, but I remember a 4-hour plus one.
That was probably the first one.
Muscular
that was probably
male.
the first one. Yeah, I was stupid at the time. So, but I did. I'm
glad we shared that moment together, by the way.
We bonded over trauma.
Yeah, right. Exactly right.
So we did. So I started off doing this, and pretty quickly got good at doing the surgery. Every patient knew that there was part of a study protocol. The first patient, who was a lawyer, by the way, I don't know what I was thinking. First patient was a lawyer. No, it worked out fine, but they wanted to be number one, and so. Lo and behold, patients started to get better, not a little quicker, not 10 to 20.
And back then, they were in the hospital
7 to 10 days. And in fact, George's hip replacements, I remember, were in balanced suspension for the first day or two. Balanced suspension for the first day or two.
I remember the rounding. And
right.
I'm as a resident, you're just like managing fleets of patients there forever.
Right.
It's brutal.
So these patients, not 20%, not 10 or 20% better, but dramatically better. And they got up, and they would get up right away and start walking around and be, well, why are we in the hospital? And I'm like, I don't know. So we started letting them go, on day 2, day 3. And then I had a couple patients. We did it in the morning. I had a couple patients who said, well, why am I in the hospital? I'm like, well, we can't send you home. That's crazy.
Right, that's crazy.
That's crazy. So I started thinking about doing outpatient joints. But there was so many other things that had to change because we were doing general anesthesia with tons of medication. Patients felt nauseated. They got hypertension. So I went to the anesthesiologist and said, who would like to help me? And of course, no one would. So I went to a fantastic anesthesiologist we had. Her name was Heather Nath. And brand new. You remember Heather?
Oh, yeah.
She was fantastic. And she was brand new. And she said, of course I'll help. And I said, well, okay, forget I'm doing hip replacement. Let's pretend I'm doing an ACL. What would you do for anesthesia? She's like, oh, I wouldn't do any of this stuff. I do this stuff. Well, let's try this stuff. Right. So we went from general to regional, from a ton of medications to very little medications, and patients just felt better. So that's when I started doing the outpatient protocol and played with all that stuff and really worked on it from so many different angles. Everything had to change because the patient would come in the hospital and the admission person would say, you're not going home today. What are you talking about? You're having a hip replacement. You're staying a week and a half. And so patients would be demotivated and not want to go home. So I had to change every single thing in the hospital. I had to change the admissions. I had to change PT. PT didn't want patients to go home. They wanted them to stay for a week. So again, I got a brand new PT who didn't know any better.
You're probably getting resistance every step of the way.
Every step of the way.
Every step of the way.
So I had to change every single solitary block in the hospital. But then after a couple of years of, and by the way, there was no nurse, it was me. So I would operate all day, and then I would go up to the floor at 6 o'clock and sit there from 6 until 10, making sure they got their IV pulled, making sure they were up, making sure PT came, and doing all that stuff.
And
so
everybody's like, why is Dr. Berger up here?
Right. Sure. So, but then after a while, it really caught on and patients started doing great and started going home. And then after a while, I was the outpatient guy. So a patient would come in and say, well, I'm going to stay overnight. You're Dr. Berger's patient. You're going home. What do you mean you're staying overnight?
So
that's crazy.
It became the expectation.
It became the expectation for everything. So I started doing more and more. And then I did the same thing with knees. We started 2 years later. I started doing unis and then started doing unis outpatients. Then I worked with Zimmer to develop a whole bunch of minimally invasive instruments for knees. And then started doing knee surgery. And again, the same thing. We had a little difference between hips and knees. Knees hurt a little more, needed a little bit more medication. So we changed things around a little bit. And then started doing outpatient knees. So my first outpatient hip was in 2001, 25 years ago. Yep. And my first outpatient knee was 2000. My first outpatient uni was 2002. Outpatient total knee was 2003. Since then, I've just finished doing my 20,000th outpatient joint.
That's spectacular. Yeah, and I had the pleasure of being there from 99 to 2004, all watching this, which was spectacular. I still do the majority of my knee replacements almost exactly the same way you taught me back then. I still use the same retractors, the same approach. Wow. Yeah, it's been great. And I think really the way learning, some of the audience won't care about this, but learning at a cruciate retaining sort of methodology, the way you and George have really worked with those, which I still think is an incredible implant, the 4-peg. I love that implant. I remember a pinnacle moment, and I remember with a CCJR or it was the Academy Special Day, something. I can't remember the exact meeting. It's been too long. Where you had the graph where you walked people through the discharge of and it was in your hips. And it was like, 2 days, 1 day. It was a bar graph.
Yeah.
And then it plumped, and then you're like, and then we figured it out. I remember like yesterday, your presentation, like, here's where we are. And then when we figured it out, and then you put the next graph up, and there were probably 2,000 people in the audience. I remember which meeting it was. And then you showed the flat line of same-day discharge, and the audience gasped. Do you remember, like, collectively? And I was like, that was a moment I'll never forget. That's when innovation hits people so hard. I don't remember what meeting that was, but yeah, it was. That was at the Hip Society. Was it Specialty Day?
Specialty Day.
The Academy. That's when there used to be 2,000 people in those rooms.
Yeah.
And you put that slide up, and you could hear the whole room gasp. And to think back then, that was probably, 2000?
That was 25 years ago. Well, the presentation was probably 24 years ago, maybe 23 years ago.
Yeah, you're right.
Like that. But then, everyone was against it. It was.
Oh, yeah.
It was crazy.
Took a lot
I got
of heat
crazy letters. I got crazy calls. I got, threats.
What were those letters? The letters like you're not being safe with. But what was the pushback you got?
Everything from simple concern, I don't think this is right, which is fine, to you're ruining orthopedics. In that, the fear was that if we let them out early, our reimbursement would go down because part of it was rounding on the patients.
Oh,
so
sure,
our reimbursement would go down to letters from people that I still have from the guys in the Hip and Knee Society. You will never get into the Hip and Knee Society ever as long as you live.
Just because of pushing
we will make sure that nothing ever gets published of yours. Yeah.
So let's talk about.
People were very unhappy.
Let's talk about that. Let's talk about, and it's going to transition a little bit to your practice, but entrepreneurship and bucking the status quo and being a disruptor. Tell us about what that's like, and are you passionate about doing that? Is there something inside that's like, I do want to push the boundaries?
Yeah. Yeah. If you want to get me to do something, tell me you can't.
That's
right.
That's fair.
Right.
There's something deep in there that says like, no, they can't tell me I can't do that.
Right. So, Gladwell talks about this a lot in one of his books, and part of the things is you have to be a little bit disagreeable to get things done. And disagreeable in the terms of not mean, but you have to go against the status quo and be comfortable with the fact that you're going to go against the status quo and you're going to piss some people off by trying to make some changes.
And you got to be okay.
And you got to be okay with that. You got to be okay with that. Right, exactly. And as a weird little introvert, I'm okay with that. I have no problem with that.
Yeah, some of it just rolls right off.
Yeah.
Well, I think if you look at where we are today, right, the government just removed everything all musculoskeletal codes off the inpatient only list. It just tells you that 25 years ago, you truly were an amazing innovator that has now set the pace for what hip and knee surgery all over the world will be. So you deserve the credit for that. But I have no doubt it was not easy. I have no doubt some of the shots were probably painful at times. But the good news is as you said, you were okay with taking some of them. Some of them I'm sure were a little below the belt, but nonetheless, you've created something that you can look back on, a legacy that's amazing. So you deserve all the credit for that. Let's talk about the practice, because I would argue you probably have, and you and I've talked about this a number of times, what we see young surgeons doing, building a practice, we see all kinds of things that they do, and they probably don't get good advice for some of them. You've built the most financially, I would say, successful hip and knee practice in the world, where people will come from all over the place, pay cash, do what they mean. To walk us through it, was there a moment that flipped and you realized I could do this and I can start, people will start coming from distances? When did that start happening? And walk us through that, how that evolution happened.
So I'd like to take credit for it. I can't. This was George's model.
Really?
This was George's model. George, you have to remember that back in the 80s, there weren't a lot of arthroplasty surgeons. George was the world famous arthroplasty surgeon. George was getting $10,000 cash in the 80s.
I do remember as a med student, you would do one in the morning and like maybe take a little siesta, just relax a little bit, and do another one in the afternoon back then. I mean,
but think about in the $10,000 in the 80s.
Oh my God.
I know it's like $70,000-$80,000 now, right? Exactly,
That's crazy.
exactly. But George that was George's model. Now, George's wasn't a busy model. George's busiest year,
Right.
he did 215 cases, his busiest year ever. But it was to have, I guess we call it a concierge practice now, but it was to provide high touch from both himself and his staff, and have people come from all over and charge a lot of money for it. And I wanted to adopt that model. Couldn't do it at first, of course. But then as I got busier and busier and busier and busier, the light switch moment for me was my daughter's first birthday, my first daughter's first birthday. So this was 21 years ago.
Yeah.
And Marianne had a cake. It was a Wednesday night. Marianne had a cake, and I was supposed to get home early, but naturally, the OR ran late, and they didn't have staffing, and I got bumped, and I missed my daughter's first birthday cake. Which, by the way, we did something different for all the years subsequently, is that your kids have no idea when their birthday is. You can tell them it's on a Saturday.
Right?
Exactly.
That's fair.
And until the girls started school, their birthdays were Saturdays or Sundays. Whatever was closest.
Totally fair.
Yeah, exactly.
Yeah, right.
Anyway.
Let's not stress the parents out too bad. But
Exactly.
Right, exactly. Was that your oldest? That was my oldest. So that was 21 years ago. Yeah.
So I decided at that point that I was going to drop out of Medicare.
That was the moment?
That was the moment. I had run the numbers.
No, wait. What year was this? What?
That was 21 years ago. So that was 5.
Holy cow.
2005. So I talked about it a little bit before, and the practice was like, well, I don't think you should do it. And anyway, so at 2005, I decided I'm dropping out of Medicare. That's it. I'm done. I ran my numbers, and the numbers were that 41% of my cases were Medicare, but about 15% of my income was Medicare. So I said, would I lose 15% of my income to have 41% more free time? Of course I would. So I dropped out of Medicare. Now, the next year, I just got busier still with private pay patients. And my numbers fortunately never went down, except now I dropped out of Medicare. I was having patients pay for Medicare to come see me. So not only did I make more private, but I also had Medicare patients. And after that, I subsequently dropped out of most insurance companies.
It's amazing. It's amazing to me that you did that so long ago, and people are just now starting to sort of talk about it. When you did that, though, it coincided with your recognition of the same day discharge happening at the same time. Is that right?
Well, actually, that was a little bit before. So I started to get busy as normal junior partners do.
Right.
But when I start doing outpatients, and I tell all my residents and fellows that you could put up a billboard anywhere you want, but you don't want those patients. Those patients are influenced by billboards. So unless you're going to keep that billboard up there for the rest of your life and pay for it the rest of your life, that's going to come down. Someone else is going to put a billboard up, and that patient who came to you is going to go see someone else. So you don't want advertising patients. You want patients from word of mouth. So I took great care of patients, had a great staff, and got word of mouth. Our practice at Rush was not driven by internists at all. In fact, we would send patients to the internists. They would never send them to us. So it was really by word of mouth. So I got more and more patients to come in through word of mouth.
Now, how did it start getting to this thing where people are traveling all over the place.
So what would happen is I'd operate on someone here in Chicago who would have a house in Florida, and they'd go down, and Berger did my knee. Look at my incision this big, and by the way, I walked out of the hospital 3 hours later.
And they're like, what?
Right. Exactly. And then, so they would come see me. So then I would get an enclave.
And they may live somewhere else.
Right. And then, they would be down in Florida, and then they would know someone, and they would know someone, and they would know someone. And so I get patients coming from all over. So now I get 50% of my patients that are further than about a 5 or 6 hour drive.
That's pretty awesome statistics.
So as I got busier and busier and busier, I also realized that I couldn't say yes to every patient. There was just too many patients calling, and I started ramping up I started listening to Bob Booth, who was one of my best mentors. He was fantastic.
Yeah, one of the best speakers I've ever seen.
One of the best speakers ever.
Yeah.
The greatest guy, funniest sense of humor, and also a fabulous surgeon. But he was really into treating people well, which we'll get to later, but also efficiencies in the OR. He would do a really great knee, skin to skin, in 20 minutes. And unless you've seen him do it, you'd say, it can't be done or it can't be good. You're wrong on both counts.
He
can
is
be done.
the person that gets credit for that, without a doubt.
He's amazing.
And
so he taught me a lot of stuff about efficiency. So I started getting more efficient in the OR and went from doing 5 cases a day to 6 cases a day, 7 cases a day, 8 cases a day, and now I do 10 cases a day. I do them at my surgery center. So I did 10 cases today. Started at 6, ended at 2:30, and came home and worked out before I'm doing this. So as I got more efficient, even being more efficient, I couldn't handle all the patients. I was doing 1,400 cases a year, and still there were more patients I was turning away. So I said, well, rather than turning away patients, I'm just going to drop out of Medicare and all the other insurance companies. So I started to do that, one insurance company at a time. And fortunately, I'm lucky enough that my numbers never went down, but my revenue went up.
That's spectacular. And if you could contrast that to George, 215.
Right.
What a journey from that to where you are now, which I think a lot of surgeons, 215, you probably can't sustain an arthroplasty practice. You can't even do it at 215.
No.
It's impossible.
No, it's possible. Yeah.
It's phenomenal. So you mentioned Bob and George. As we reflect back on your career, let's talk about mentorship for a minute. I want to get back to the teams and building what you built. But let's stay with Bob a little bit. Tell us about mentorship and both Bob and George influencing you, and then your influence teaching residents, fellows, et cetera.
Yeah. Bob and George were just phenomenal mentors. Not only were they just, incredibly smart, world-renowned, great surgeons, great speakers, they just had genuine kindness. They were always there.
And they took an interest
always.
In you, right?
They did. They did. And Bob, it was funny. I started doing outpatient joints, and everyone started complaining to George. And George,
they complained to George.
They complained to George. Well, they complained to me first.
It's like when kids are like, go tell his mom what he's doing. Well, right?
They complained to me first, and I kept doing it. So head of PT, head of anesthesia, everyone's complained to George. And George sat me down in his office and said, Rich, I don't think you should be doing this.
Was that right?
Yeah. George sat me down and said, you know what? And he didn't say, you cannot do it, which he could have. He could have. He was department chairman. Whatever. Oh, yeah. But he said, Rich, I don't think this is a good idea. I don't think you should do it. And it was hard for me to say, but I said, basically, I respect you a ton. Yeah. If you forbid me to do it, I, of course, won't, because I won't go against you. But I think this is something that's good. I think this is something we should do. And I'm going to continue to do it.
What did he say?
And he just said, okay, but again, I wish you wouldn't. But I did.
I wish he didn't stop.
No, he didn't stop me. To his credit, he came back a year later and said, "You know what, Rich? I was wrong. You were right."
It's a good mentor.
Yeah, it was great.
That's humility that not all. Yeah, that kind of humility not everybody has.
Oh God, no. And then I spent a ton of time with Bob Booth, and learned just so much from him about everything. And he was really.
He wasn't local. Was a lot of that through Zimmer, or
a lot of it was through the speaking circuit, and right.
Yep.
Yeah, I got to be friendly with him, and Marianne got to be friendly with him. He would seek out not me, but seek out Marianne to sit next to Marianne, and I just tagged along.
I can't believe.
Yeah, exactly. exactly.
Can't blame him.
Right. Yeah, I can't blame him either. And actually, probably, if she would leave me for anyone, it would have been for him. But I wouldn't blame her either. He was great. Anyway.
You're in much better shape than Bob was.
Yeah. Anyway, but that was it. So I learned a ton from Bob, but I also learned about mentoring, and I really try hard to be good mentors to the residents and to mostly the fellows who I spend a lot of time with. We do this book club every month where we go and talk about business books and management books and how to be a better person books.
Yep.
And I give them a book a month, and we go to a restaurant or something, and we sit and discuss. And then I have a meeting with the residents most Tuesdays where we started off doing cases. And I realized that most residents don't go into arthroplasty, and they'd be bringing these crazy revision cases, which was fun for me, but you're going into hand. Why do you care? Right. So I said, okay, let's stop this. Let's talk about life. Let's talk about running a practice. Let's talk about all of the other things, the things that I do the first day of the meeting at our Vail meeting.
That's spectacular.
All of the other things that are relatable, whether or not you're going to hand or sports or joints.
Right.
And talk about your first contract, your first job, where you need to be successful, where you need to be successful in your personal life. I talk about money. They can ask any question they want,
that's right.
And I answer every question, much to my partner's chagrin, honestly.
Well,
honestly.
That's why authenticity is what drives people. And that's what your course that you do in Vail, that's probably, without a doubt, the most popular fellows course is it's modeled after your mentorship model, seems like, right? It's structured that way.
Right.
Let's take the first day and talk about stuff that's not hip and knee replacement cases. Talk about running a business, which they gobble it up. They can't. You could do a week on that, I think, with their desire to learn.
Easy, because it's the one thing that's so important that we don't cover. Some people do go to management school or have a business degree, but most people don't, and they get into practice, and half of practice is running a business. And you have, just like you.
I was the worst case example. I left Mayo Clinic, and the pure academic model went out and got my ass handed to me in practice. I was like, what?
Yes, you did. On a couple different places.
Yeah, more than once, right?
Yeah.
It takes me a while to learn. I'm like a little thick-headed. So, so I remember sitting at the first board meeting, and they pass out a book, and I'm like, this is so embarrassing, but I say this to, because I mentor very similar, like I don't want people to make that same mistake. I didn't know what accounts receivable was. But no one.
Why would you know?
I was too worried about watching the Figure 7 graft and like doing all that stuff. Like no one ever told me about accounts receivable, and I'm like, what is this? And I'm like, felt so embarrassed. But we, and I still don't think we do a great job. I think the reason that I'm sure that's popular is because you answer honestly to things that, and I don't know why we don't, as physicians, we seem like we can't talk about money. Right. But healthcare is predicated. It's 20% of or 18% of our GDP.
Yeah.
To not be able to talk about the financials is probably inappropriate to some degree, but we don't.
It's completely. I learned a lot initially from my wife, who was in corporate America, and she taught me a ton about managing. She was a manager. She managed 100 people below her at one point, and hired and fired all the time. And she would teach me about interviewing, about managing people, about business, about all this stuff that I was an engineer. What the hell did I know? Nothing, right? So I learned a ton from her, and then now have started to try to pass this on. But there's a couple of really good quotes. One of them was from my wife, which is that she would say that if the person she was interviewing didn't ask about their total compensation the first or second question, either they weren't serious, in which case the interview was over, or they weren't motivated, in which case the interview was over. And think about that for residents, fellows getting a job. They go to dinner, they do it, and then the last question is like, well, kind of, are you paid? Am I going to make money? Do you think maybe? Right.
It's totally true.
And that's and the other thing is that those who don't want to talk about money will always be taken advantage of by those who don't mind talking about money.
Yeah, that's fair. That's fair. So so great segue. Let's talk about people. Let's talk about your team. Because I don't know this. I'm assuming that Marianne was influential in helping you learn how to build a great team. Your team is spectacular, right?
They're fantastic. Right? They are so much better than I am. They are the high point of my practice.
So talk about that team. management of the team, building the team, and what that team does in patient care. Walk us through that, because it's a unique practice.
Sure. I was having one of my best friends, surgeon. We were having lunch. This was a very long time ago. He was telling me about his sister-in-law, who was in the hospitality industry, and he was telling me how different it was, the practice of medicine versus hospitality. And I'm listening to him and suddenly realizing that it's not at all different. It's completely the same. They would talk about the experience. We talk about surgery, but no, we need to offer an experience. So I love good customer service wherever I am. I look for it. Every place I go, I find good customer service or look at and try to pick apart what they're doing wrong so I could do better. It's a craziness that I have. So, but I wanted to bring that to my practice. So we do great customer service, a great experience from the time you call, through surgery, of course, through the time you're done. So when you call, you don't get press 7, press 4, we care about you, we're going to call you back. You get a person. Hi, Dr. Berger's practice, can I help you? And their job is not to get an appointment on the books. Their job is to spend 10 or 15 minutes with that new patient on the phone, figuring out what their problem is. They're really smart. They're admins, but they can diagnose hip and knee arthritis over the phone, super easy. You got pain in your hip going down to your foot, you probably need to see the back doctor, not Dr. Berger, right? So subsequently, my hit rate in the office is 100%. But they talk and they make a good connection with those patients, so the patients feel valued and cared for, which they are, and making sure that we're the right practice for them and they're the right patients for us before they come in. Then when they come in, the same person they talk to on the phone, they get the Walmart greeter in the office. Oh, hi, Dr. Meneghini. Remember we talked on the phone. It's so good to talk to you again. Now let's get the paperwork done, which hopefully you filled out beforehand because we sent it to you beforehand. The whole package is sent to you when you make your appointment to fill everything out, everything, all your questions. Now that person brings them in the room and sits with them and explains all about what's going to happen, all about the surgery, all about everything. Then they'll see one of the
And probably at that point, the patient is already starting to decompress a little bit. When they come into the physician's office, they're nervous. I'm like, oh my gosh, I got this hip pain. I'm going to have to go to the surgery. But as these people spend time with them.
Right. And they spend a ton of time with them.
That's
right. And so
and they're extension of you.
Right. And usually one of the residents or fellows or one of the nurses will go in first, and then I come in and, talk to them and figure out what they need and da-da-da-da-da. Yeah. And then I will leave them with the nurse again. I will bring in one of the nurses, and I have fantastic nurses. They're young, they're happy, they're joyful. They are super enthusiastic. They're just wonderful people. And I don't want to talk to me. I'd rather talk to them. They're fantastic, right? So they get to talk to them, and they are absolutely fantastic. And so then they'll talk to the nurse a little bit more. We used to do a teaching class in person. We now do it virtually, but they get everything signed up. They'll do a virtual class where usually one of my nurses, Jenny, runs, where it's an hour and a half class that. And now it's high tech because we have, slides and we have videos and we've got everything. We'll show them videos of the surgery center that they will go to make them feel more at ease, which actually really, really is
so
nice.
You show them pictures, like a virtual tour of where they're going to go.
Yeah.
That's great.
Yeah, it's great.
That's awesome.
It's great. And then they'll finally come in and have the surgery done. They get the surgery done, then they usually discharge 92% of my patients. My primary joints went home last year, so most of those patients go home. And then the next day they'll get a call from one of our nurses, and then 3 days later they'll get a call from another one of our nurses, and then a week later they get a call from one of our nurses. Every patient gets my home telephone number. Every single one that I've operated in for the past 30 years has my home telephone number. Happy to have them call, and they call. They also get, I have cell phones for all my nurses, all 7 nurses I have. They have cell phones, and they get that on the list too. If you feel more comfortable talking to me, call me. If you feel more comfortable talking to any one of the nurses, call them. on their cell phone, they will answer. You don't get an answering service. You get one of us. So you don't have to explain, oh, I had surgery 3 days ago. Oh, someone will call you back in an hour. No. Oh, hi, Mrs. Jones. Yeah. Oh, I know you had surgery yesterday. What's going on?
So I think that one of the things I'm passionate about, the same thing you are, Rich. It took time to learn it. It's the Ritz-Carlton model where, and other industries do it far better than we do, but we need to learn, study, understand that experience, because I think you're spot on. You have a huge staff. It's an amazing picture that is you in the middle of you have criteria. They all look attractive. They're all women, and they're all a certain age group. That can't be not by design.
Well, I mean,
to some degree.
I hire staff that has no experience. I don't want them to have experience.
No medical, like they're not.
God, if you have medical experience, I won't hire you. No, I'm very, very serious. If you're an admin and you've worked in medicine, I won't even interview you. You're out.
Medicine is not the center of customer service at all. It's like the worst, right?
It's the worst.
Ask you 18 times how many allergies you have. It drives me crazy.
It's the worst customer service. And they're patients. Because they're patients, we don't have to treat them well. So my admins are one was from Lululemon, who waited on me.
You'll go into a store and they'll be like, she was really good.
Yeah, I'm like,
hey, do you want to get a raise?
Yeah, exactly. Exactly.
That's spectacular.
Yeah, Skylar's one of the women who worked for me. Was one of our waitresses. Came over. She was doing a bunch of tables. She was happy. She was joyful. She was great. She was happy. She was joyful. She was taking care of 10 tables at once. I'm like, do you want to move to Chicago and work for me? She's like, yeah. What do you do?
Yeah. You went, oh, that's spectacular.
Yeah. So I hire people who are enthusiastic with no experience, and that means usually young. Now, Andrea's worked for me for 30 years. Jenny's worked for me almost for 20.
That's a testament, right? That's a testament to how you treat your staff. Yep.
But most of the people are going to be younger. This is not their lifelong ambition.
Yep.
They're going to come. They're going to work for a couple of years. They'll have a great time. I pay them extremely well.
Yep.
And I'll sit down with them and help figure out their life and what they want to do. If they want to go someplace else, some want to move to California. My staff have gone to PA school. The admins have gone to nursing school. The admins, 2 are going to medical school now.
Wow, that's awesome.
And so they're wonderful people. This is a stop. And they work for a couple years, so then I have to hire someone else. And again, usually someone who's younger, but only because they have enthusiasm and no experience.
How big is your staff? How many do you employ?
I now have 19 people that work directly for me,
19.
that I pay.
That's got to be the largest hip and knee replacement staff I think that exists for a single surgeon, without a doubt.
Yeah, and it's a lot of money that I pay for.
But you invest in that experience.
I pay for.
So
exactly. Because I want to provide a great. So what I started off doing was, I was trying to get the George model of concierge, and I didn't have enough help. So certain patients would get better care than others, and I hated that. I just hated that. I wanted to give fantastic service, whether you're Bill Gates or the teacher around the corner.
To 100% of your patients.
I want to give this experience to, which requires a lot of help.
It does.
A lot. Now, it makes it easier when you're out of insurance because I can make more money to pay for that.
Per unit.
Exactly. But that's the experience I want to give to everyone. I don't care who you are. I don't care where you are. I want to give that experience.
So do you think, let's talk about this move with AI and technology. Can you think that a staff of 19 do you think it will ever shrink given technology? Because there's a lot of people that are trying to replace staff with automation to some degree.
Yeah.
What do you think about it in your concierge practice? Do you think humans are really the ones that can deliver that?
So I'm going to ask you a question in return instead of answering the question. You just had surgery. You're having a problem. Do you want to talk to a person or a computer?
Person all day, every day.
Of course.
Yep. You and I feel the same.
That's simple. That's simple. And yeah, I'm sure there are ways of extending and getting some common questions answered or whatever. Maybe I'm just old. It pisses me off so badly when I call and I get some AI person. And because more likely than not, I have to go through a whole queue.
Of course.
And then I still can't get what I want, and now I got to talk to a person. You just wasted all my time. And it hasn't saved anything.
It's frustrating.
It's incredibly frustrating. I don't want that. I want someone to call, pick up the phone, and me or one of my nurses or one of my admins answer and say, of course I know who you are. What's going on? Oh, yeah. Okay, that's normal. Or, oh, God, that's a problem. Let's see you right away. Let's get you to the emergency room, whatever.
Yeah. So we've talked about probably, and I really appreciate you sharing insights into what goes into and created in your journey of probably, I think, the most successful hip and knee practice on the planet. I want to turn a little bit to family, life, balance. How do you manage all of that, and how have you successfully managed? You have two very successful children, daughters. Tell us how you manage all that, and what's your approach to life now? Did you say 60 years old? Is that what you said?
I am 63.
So tell us your approach now.
So, oh God, I could go off on so many tangents, but I think the first thing to do is just think about is what you're going to spend your time doing and what you want to do. Every resident fellow now, the number one thing they want is work-life balance. I don't know what work-life balance means, to be honest with you. The best definition I heard comes from Simon Sinek, which is that work-life balance is when you're as happy at work as you are not at work. So it has nothing to do with the hours of the day. It has more to do building your world, which I've done, that is a happy, joyful world. I'm so fortunate. I get to take care of patients. You do the same thing, hip and knee replacements.
Yep.
You know, 99% of the patients come back. You've saved my
blessing,
life.
yeah.
You gave me my life back.
Yep.
They're unbelievably happy and grateful. They're crying how wonderful it is. If you can't get joy out of that, something's wrong with you, right?
Okay.
And then I have wonderful people around me who I really, truly enjoy working with in the office, but also in the OR and in the surgery center as well. And I really enjoy spending time with them. I love what I do. I'm able to focus pretty well. When I'm in the OR and operating, I don't think about anything else. And when I'm here with my wife or my kids, I don't think about work. So
you're able to walk in the door.
I walk in the door and leave it, and when I'm there, I walk out and I leave it.
And that's like quality versus quantity. Because I've seen, and I'm sure you have too, our profession can be challenging for people and their families. And sometimes people mistake, in my opinion, I'll be interested in what you think, they mistake spending just more time, but they're not really dialed in for the family. But you're able to do that, it sounds like.
Yeah, and because I dropped out of the insurances early, and this was one thing I learned from Bob Booth, and I was super fortunate to get into lecturing around the world with a bunch of very famous people, and I sat down, and Mary and I would sit down with them. This is before we had kids, and asked each one, if you did something different in your career, what would be different? What would you change? And many of them said what Bob Booth said, and it stuck mostly when Bob Booth said it. He said, I would spend more time with my kids. Mm-hmm. And I got that information very early in my kids' life. So what I was able to do was I took every day they had off school off. I took 3, 4, 5-day weekends every summer. If they had a school conference day, I took it off. I would start patients late on Mondays so I could drive each kid to school separately. So I got to spend a lot of time with them. Now, maybe for their benefit, but to be honest with you, more for me.
Yeah,
I like spending time with my kids. If you don't like your kids, please don't spend a lot of time with them, right? But I really enjoy spending time with my kids, and I still enjoy it. We just got back from Iceland. We took a 5-day trip to Iceland, which was great, by the way. But both girls came, 20 and 22, and we had a fantastic time.
And they like coming with you, of course, which is great.
Well, they can't go any other way, right? But yeah, right, exactly. But yeah, we had a wonderful time.
Yeah.
The other thing that's interesting to think about is that if you ask parents, it was a great study on this. If you ask parents, what's the most valuable things kids would think about parenting, they would say spending time with their kids. That's what they thought the kids would say. When they went back to the kids, no kid said that. Kids just said, I wish mommy and daddy would be happier when they got home.
That's right.
So it doesn't matter how much time you spend with your kids. No matter how little time you spend with the kids is more than my dad spent with me, and more than the last 50,000 years what parents spent with their kids.
Correct.
But when you get home, enjoy spending time with the kids. Leave stress at work, and spend time with your kids.
It's fantastic that you talk about that, because it sort of reshapes things. Instead of this work-life balance thing, it's really finding joy and putting a big emphasis on your work to make it a place that you have more when you come home. And I think people get it backwards. They're like so focused on the home, and then they're all, and especially lately, physician burnout's at an all-time high. Everybody's miserable. So what do you expect them to your point, what do you expect them to bring home with them if they're so miserable at work, right? There's a lot that goes into that. But I think that's a very good reframing of the term work-life balance, which I hate.
Yeah.
So
I get, I'm fortunate. I have wonderful girls, and they're grateful. But I get notes and cards from them regularly. Daddy, thank you for working so hard.
Yeah.
I know you work so hard. Thank you for working so hard.
It's also leading by example.
Yeah, exactly. Right. So hopefully they'll have a good work. Who knows? But hopefully they'll have a good work ethic. But we'll see. But I think if you do that, your kids appreciate it, I think.
Yeah. So, you and I have talked about this. We joke about it all the time, actually, and it's very true. But both of us married up.
Very much so.
Right.
Very much so.
For me, I couldn't do what I do without Sarah. It's impossible, because without that support, I assume your amazing wife Marianne is very
Marianne
similar.
is fantastic.
Right?
Marianne is fantastic. She supports me. She obviously, supported the kids and still supports the kids. It's amazing, even though they're out of the house, they're still not out of the house, and they still need a lot of help.
But she had a role in your practice too for a period of time,
she
right?
She did. Well, she still
does.
she still does. I worked hard at trying to be a good manager and a good leader, and I think after 20 years of doing it, I suck less than I used to suck. But I'm still terrible at it. I'm not the happy, joyful extrovert guy that people naturally flock to. Marianne is. So Marianne really taught me a lot about doing that. Plus, you got a bunch of women that, quite frankly, I don't relate to very well.
Yeah.
I don't.
I think that's fair. And you know that. That's humility.
And I know that. And I know that. I know that they tolerate me at best. So Marianne has been really, really good and helpful at really helping to manage the practice, really helping to get people in the practice, working out, when you have a bunch of type A women together, someone's always being voted off the island, always.
Yeah.
And
that's fair.
Voted
off,
you're right. It's, and this week it's this person, and the next week it's, they're back in and someone else being voted off, right?
Totally
but it's always right. And Marianne is really, really skilled at talking with them, diffusing the situations, and making it better. And she still does that. Not only do I get to talk to her and bounce ideas off her and everything, but she'll actually come and do a stop by the office.
Yeah.
I was just
a check-in.
I was just stopping by. She really wasn't. She planned on doing it, but right. So she just stopped. But she just stops by and just checks in with everyone and makes sure everyone's good and there's no problems. And sometimes they're like, "Well, can I talk to you in the office?" Right? And then she'll go and talk to them, whatever.
So I want to finish with a question that you just phrased, and I've asked a similar question. Do you have any regrets? Looking back now, anything you would do differently? Because it's pretty hard to replicate what you've done.
Yeah.
It sounds pretty great.
Yeah.
Is there anything you would do differently?
For me, I think it's like the butterfly wing. That if I did any little thing different at all, I have a perfect life. I mean, it is wonderful. I've got a fantastic wife. I got fantastic kids. I got an amazing practice. I have everything I could ever wanted 10 times, 100 times over. So if I changed anything in my life, it couldn't be better. It could only be worse. So the long answer is no.
Rich, talk about treating people well. You have 19 staff. Talk about keeping those people loyal, how you treat people around you. You go to a bunch of ASCs. You have all these people around you in your sphere that you need to do your job. Tell us about your philosophy of treating people around you.
So one of the wonderful things about being an orthopedic surgeon is that the bar is so stinking low. It really is.
Fair.
It is amazing.
That is so fair. I agree with you.
If most of the surgeons you probably trained with, except for me, of course, but if most of the surgeons were treated by their department chairman the way they treat their staff, they would quit. They would quit.
It's fair.
Right? Their mother told them they were special, and they believed them. You're not special. I mean, I like to think I'm the NFL quarterback. I get money, I get prestige, I get fame, but without the other team members, I'm just a guy with the ball with 11 guys on me.
So let me ask you that. Did your mom tell you were special?
I had a Jewish New York mom. No.
And I have a Midwest mom who grew up in poverty.
Yeah.
My wife laughs at me because every time, and my mom has passed away since then, but when Sarah came into our house, she was like, anytime I'd be like, starting to do a little bit of a self-pat, my mother would be like, "You're not that good."
Yeah,
and I was like, "What?" She's like, "Yeah, you're not that good." Like I was like, "Oh." Sarah's like, "Did you?" I go, "I grew up that way." Yes. So anytime I started to get a big head, she's like, "No, you're not good."
So this was like 10 years ago, and my mom since passed, but she was having some knee pain. So I'm like, it's probably arthritis. I don't think so. I'm like, well, let's get an X-ray. So we got an X-ray. She's in New York. I'm here. Gets the X-ray sent. She's got arthritis. So I called her back and says, "Mom, you got some arthritis." I'm going to go see someone who knows what they're talking about.
the mother of world famous Rich Berger says, no, I don't think so.
So I sent her to Gil. Who was really nice. She was really sweet.
She's like, he knows more than you do.
Yeah, exactly. So he knew more, and he was great. But anyway.
But that helps you probably in your day-to-day, that humility. You know that people want to be treated.
You have to have a big staff. You have to have people around you, both in the operating room. I mean, it bewilders me for surgeons that don't treat their staff well, right? I mean, one of my 3 goals in life, and I have goals, and they've changed over time, but the first one is to be a good husband. Second is to be a good father, because you got to be a good husband before you're a good father.
Totally agree with that.
Because if you and your wife are on different pages, you can't parent your kids. And number 3 is to help as many people, not patients, people as possible. And people in the OR and your staff are people too. So it bewilders me that surgeons are going to treat their patients so well, who they just met, and their staff who they work with every day, they're going to treat horribly. That seems backwards to me.
Totally agree.
Right? So I love treating, I truly value and appreciate them. I tell them that every day. The last time I yelled at my staff was never. Why would I yell at my staff?
Right.
They're there to help me. They're trying their best. And yes, sometimes the pants fall on the floor, something crazy happens. Hopefully they don't hurt me. Short of that, we'll get through it.
Right.
And I support them. I love when they screw up because it's my chance to show them that I value them.
Yeah.
Not just when they're good, but when they screw up too.
To give them grace and tolerance.
Exactly.
And to bring them right back up.
Grace is my favorite word in the English language, right? What do you do to earn grace? Nothing. It's a gift given to you that you don't deserve. Therefore, what do you do to get grace taken away from you? Nothing, because you didn't deserve it to begin with.
No.
So I try to give everyone grace. I try to be a really great mentor to the residents and fellows, but my staff as well. And because I know without them, I can't do anything.
Yeah, and that breeds loyalty. That's good leadership, good management skills. That breeds loyalty. I think there's no doubt.
And I only hire people in the operating room. So my nurses, I teach them how to scrub. They're brand new nurses. They've never scrubbed before. If you scrub before, you can't scrub with me. And I spend a couple of months slowly teaching them every step. And I believe, there's a sink or swim mentality, which means you either sink or
you can see pretty quickly.
Or you get water in your mouth, which is horrible. So I don't do that. They will watch a little bit, then they double scrub. Then the good scrub, the one who's teaching, will hand them an instrument to give to me, and everything's perfect.
And you can probably see pretty quick whether they're going to get it or not, right?
Easy.
No self-select.
So easy.
Yeah.
And I teach them, which creates incredible loyalty because they're not stupid. I gave them a chance when no one else would. And everyone in the hospital and the surgery centers, well, Berger gets the best people. Well, yeah, I do, because I picked them and trained them, and they're incredibly loyal. And those people, none of the other guys would take to begin with. Now that they're great, they all want them. But at the first, they wouldn't take any of them because they didn't know anything. Right. So I love teaching, not just resident fellows, but my staff as well, and particularly the people.
That's a great lesson
in the operating room. And you get incredible loyalty. So I have staff now that follow me from Rush to the different surgery centers. They only want to be at Rush when I'm there. They won't scrub with anyone else, and they follow me to the surgery centers.
That's a great point. We recently had to let a surgeon in our group go, not because he wasn't a good clinician, he's a great clinician, because of the way he treated the operating room staff. And it kept recurring and recurring and recurring. It's amazing, to your point. I've always said that I think sometimes those surgeons who lash out in the operating room maybe aren't as comfortable in the operating room. And I don't think they're inherently necessarily bad people, but they get uncomfortable. And so instead of turning the mirror on themselves and figuring out how to deal with figure out how to get out of that situation, there's blood, whatever, they lash out at other people. I've always wondered if there was a little bit more, it's complicated, but I wondered if the surgeons sometimes lash out because they're not comfortable.
Yeah, I think so. But it's also the ownership thing. There's a great book called Extreme Ownership. I don't know if you read it, but talks about how everything that happened is your fault and you need to own it. Everything that happens. For a couple of reasons. Number one is the captain of the ship needs to take in charge. And even if it's not my fault, it's my responsibility. So I will take it on for sure. Two is that if it's someone else's fault, they're not going to fix it. If it's my problem, I will fix it. It won't happen again. But also, once it becomes your fault, why yell at anyone else?
Yeah, and I think that's great. There's some great, it's a basic leadership principle that I hear people make mistakes all the time, which is when you succeed as a team, you say we. When you fail, you own it. It's amazing how many times I watch people go the exact opposite of that. It's not that hard, really. Everybody's winning. You're doing great. The patient's doing great. We have a great team. I don't even like getting compliments from patients.
Oh, I feel so uncomfortable.
It's the worst. I'm in the room and they're like, "Oh, we Googled you. This is latest AI said you're the best surgeon in that region." And I literally will be like, "No, I have an amazing team." They're like, "What?" I'm like, It feels horrible to get that. And I don't know why. Maybe it's something my mother did. I'm not really sure, but it doesn't feel right.
We have the same crazy moms.
In the back, I'm like, "You're not very good." So it feels weird when Google AI says I am. Like, no, my mom says I'm not. But anyway, I think there's something about that where when you win, it should be a we, and when you lose, the captain of the ship should say, "I've not." Ultimate accountability, and it also saves your staff from that feeling, right? I think that's great.
What you're there for. My kids call it now the Peyton Manning effect.
Oh, a little Indianapolis Colt. I love the props.
My wife, who is a huge football fan, was following Peyton Manning from Tennessee because her dad played for Tennessee in the Rose Bowl a million years ago. Leather helmets, but so she would follow Peyton Manning. But if you ever watch Peyton Manning in a press conference, it was amazing. If they won, right, the press would say you played great. There's like, no, I had a great line. I could have been better with the ball.
He was probably the best at it.
He was so good.
Yeah.
He gave the credit to everyone else. And when they lost, they would say, "Oh, you had line." No, it was my fault.
I could play better. Yeah,
I could have played better. No, the line played great. I could have released the ball quicker. I could have better. Who wants to play for that guy? Everyone.
He bought his entire line Rolexes.
Yeah.
When they would win. I mean, he was a great leader. There's no doubt about that.
When you succeed, you give everyone their share. And when you fail, it's your responsibility. Everyone wants to play for that.
Great leadership.
Right? Remember Cam Newton, the opposite?
Yeah.
Right? Superman when he wins, little hoodie after he loses the Super Bowl, blaming everyone else.
Right.
Who wants to play for him?
Nobody.
No one, which is why he was in the league so short.
That's exactly right.
Right? It's really no different being a surgeon because you're the leader. You're the leader in the operating room. You're the leader in your office, and you need to take responsibility.
I think that's a great lesson. I think that's absolutely a great lesson.
Yeah.
Well, my friend, cheers. Cheers to that. So cheers to that. Cheers to Marianne and Sarah, our beautiful wives who help us do what we do. And from my heart, I want to say thank you for an incredible interview on this podcast, for opening up and giving people a glimpse into what makes the world famous Richard Berger, who he is and how you got to where you are. So thank you so much for being on the podcast.
Thank you. It's just been such a delight to talk to you. It's been so easy to talk to you, and that's not me, as you know. So you are very skilled at this, so thank you. And thank you for being a great friend, and thank you for all the hard work you put into the Vail course, and I appreciate you so much.
Thank you. Cheers.